with edema. 5 simple rules for happy life. Don't ever quit, never back down. Don't be Don't make things complicated, keep it simple. Don't be a grown up, stay as youthful as kids. Don't take things too seriously, laugh at problems. Assalamu alaikum. My name is Dr. Sadia Rafiq, and today my topic of presentation is chickenpox, varicella. Learning outline short, introduction of chickenpox, epidemiological triad, chain of transmission, clinical stages, levels of prevention, and recent advances. At the end of the presentation, you should be able to describe the epidemiological triad and the prevention aspects of this infection, understand the factors that contribute to its spread, enumerate the differences between the smallpox and chickenpox, and the knowledge of recent advantages. Etymology, true sense. How the term chickenpox originated is not clear, but it has been said to be derived from chickpea, based on resemblance of the vesicles to chickpeas, or to come from the rash resembling chickenpox. Not surprisingly, chicken gets chickenpox too, except in their case it's called fowlpox, and like a human version, it is contagious viral disease with no cure and treatment. Introduction of varicella. It's acute, highly infectious disease caused by varicella zoster virus. The recurrent infections, herpes zoster, shingles, has been recognized since ancient times. Primary varicella infection, chickenpox, was not distinguished from smallpox until the end of 19th century. Worldwide in distribution and occurs in endemic and epidemic forms. Chickenpox and herpes zoster as different hosts respond to the same etiological agent. Problem statement. Global annual causes of disease death, 4.2 million severe complications leading to hospitalization and 4,200 deaths. In pre-vaccine era, in developed countries, case fatality rate was about 3 per lakh cases compared to 1 per thousand million cases. The incidence and severity of herpes zoster increased with age, marked after 50 years due to decline in immunity. Adults who reached 85 years now would suffer at least one episode of herpes zoster. Epidemiological detection includes agent, host, and environment. First, agent. Varicella zoster virus, called human alpha herpes virus 3. Primary infection results in varicella, chickenpox. Recurrent infection results in herpes zoster, shingles. Host factors: age and children under 10 years of age. Few escape until adulthood but can be severe in adults. Immunity. One attack gives durable immunity. Maternal antibody protects the infants for few months. No age exempt in the absence of immunity. IgG antibodies persist for life and correlate with protection. Cell-mediated immunity is important in recovery. Pregnancy, risk for fetus and neonate. Environmental factors, it shows a seasonal trend occurring mostly during the first 6 months of the year. Overcrowding, temperate climate, there is a little evidence of seasonal trend. Source of infection, usually a case of chickenpox, virus present in oropharyngeal secretions and lesions of skin and mucosa, rarely may be a patient with herpes zoster. It can be isolated from the vesicular fluid during the first 3 days of illness. Infectivity. Period of communicability 1 to 2 days before the appearance of rash and 4 to 5 days thereafter. It tends to die or before the pustulous stage. Patient ceases to be infectious once the lesion has persisted. Secondary attack rate about 90% in household contacts. Transmission. Droplet infection and droplet nuclei, face-to-face personal contact. Portal of entry is respiratory tract. Virus is extremely labile, so fomites unlikely to transmit. Contact infection plays a significant role when an individual with herpes is an index case. Congenital varicella, it crosses the placental barrier and infects the fetus. Incubation period ranges from 15 to 16 days, but usually it is from 7 to 21 days. Varicella pathogenesis. Respiratory transmission of virus, replication in nasopharynx and regional lymph nodes, repeated episodes of viremia, multiple tissues including sensory ganglia infected during viremia. Clinical features may vary from a mild illness, hopefully scattered lean, to severe febrile illness with widespread rash. It has two stages, pre-eruptive stage and eruptive stage. Pre-eruptive stage. Onset is sudden with mild or moderate fever, pain in back, shivering and malaise. Very brief stay lasting for 24 hours in adults, more severe and lasts for 2 to 3 days before rash comes out. Eruptive stage. In children, rash is often the first sign. It comes on the day of fever starts. Distribution of rash. Symmetrical rashes, centripetal in distribution. First appears on trunk, abundant. The face, arms, and leg less abundant. Cause of surface generally involved. Axilla may be affected. Palms and soles usually not affected. Density of eruption diminishes centrifugally. Rapid evolution, the rash advances quickly through the stages of macule, papule, vesicle, pustules, and scab. Pleomorphism, a characteristic feature of the rash in chickenpox. All stages of rash may be seen simultaneously at one time in same area. This is due to appearing in successive coughs for 4 to 5 days in same area. Vesicles filled with clear fluid resembling dewdrops, superficial inside with easily ruptured walls and surrounded by an area of inflammation. Vesicles may form crust directly. Many lesions may abort. Scabbing begins 4 to 7 days after a rash appears. Fever not high but exacerbations with fresh cough. Diagnosis. Prodrome of low-grade fever, eruption of papule, vesicle, and pustules, typical dewdrops or rose petal appearance, characteristic centripetal distribution. Complication. It is mild, self-limiting disease. The mortality is less than 1% in uncomplicated cases. Patients at risk of complications are immunosuppressive patients, cancer patients, recipient of organ transplants, chemo, radiosteroid therapy recipients, HIV infected, and children with leukemia. The complications include hemorrhages, varicella, hemorrhagica, pneumonia, encephalitis, acute cerebral ataxia, Reeve syndrome, which includes acute encephalopathy with degeneration of viscera, especially liver. Maternal varicella may cause fetal wastage and birth defects, acute retinal necrosis, secondary bacterial infections, and pituitary scars. Congenital varicella syndrome results from maternal infection during pregnancy. Risk appears to be low, less than 2%. Period of risk through first 20 weeks of pregnancy. Congenital defects in babies include a damage to brain, damage to eye, other neurological disorders, damage to body, including hypoplasia of the limbs, and skin disorders. Varicella laboratory diagnosis includes the isolation of varicella virus from the clinical specimen, rapid varicella virus identification using PCR, significant rise in varicella IgG by any standard serological assay. Investigations are rarely required in doubtful cases. Zinc smear done from fluorovesicles, which show fluorovesicles show a multinucleated giant cells. Differential diagnoses include vesicular exanthemis, contact dermatitis, impetigo, insect bite, drug eruption, and smallpox or other pox viruses. Differences between smallpox and chickenpox. You can see the distribution of rash among smallpox and chickenpox. It is on the smallpox, it is at the surroundings, limbs at the end, whereas in chickenpox, it is abundant on the trunk. These are the differences. Incubation period is different. Smallpox is of 12 days. In chickenpox, it's of 15 days average. Prodrome is severe. In chickenpox, it's mild distribution. In smallpox, it's centrifugal, whereas in chickenpox, it's centripetal. Whereas palms are not involved, axilla affected. Characteristic of rash in smallpox is deep-seated, whereas in chickenpox is superficial, uninocular, dewdrop, pleomorphism. These are the characteristic features of the rash of chickenpox. And the evolution of rash in chickenpox is very rapid, and the fever appears with each fresh drop of rash. Levels of prevention, primary, secondary, and tertiary. Primary prevention, as we all know, the health promotion and specific protection. Primary prevention of disease by ensuring high population immunity through immunization. And the health promotion includes awareness regarding disease and everything. Vaccine. The first vaccine, live attenuated vaccine, was invented in Japan in 1970s. Vaccine was licensed for use in US in March 1995. First vaccine to reduce the risk of herpes zoster was licensed in May 2006. Mild local reaction at inoculation site is 1%. Zero conversion is healthy. Seronegative children is over 90%. It's a monovalent vaccine, one or two doses scheduled, zero point 0.5 ml subcutaneous injection. Duration of immunity probably is of 10 years. Varicella containing vaccines are: first is varicella vaccine Varivax, approved for person 12 months and older. Second is measles, mumps, rubella, varicella vaccine Procod, approved for children 12 months to 12 years. And herpes zoster vaccine, which is Zostavax, for person 30 years and older. Varicella vaccine recommendations for children are routine vaccination 12 to 15 months of the age, and the routine second dose is given at the 4 to 6 years of age. Minimum interval between doses younger than 13 years of age is 3 months. Then the recommendations for adolescents and adults: all persons 13 years of age and older without evidence of varicella immunity, 2 doses separated by at least 4 weeks. Don't repeat first dose because of extended interval between doses. For healthcare personals, recommended for all suspected healthcare personals, pre-vaccination serological screening probably cost-effective and it is not required. MMRV vaccine, approved for children 12 months to 12 years of age to age 13 years. Do not use for person 13 years and older. May be used for both first and second doses of MMR and varicella vaccine. Minimum interval between doses is of 3 months. Herpes zoster vaccine, single dose among persons 60 years and older, may vaccinate regardless of prior history of herpes zosters. Person with chronic medical conditions may be vaccinated unless a contraindication or precaution exists for the condition. Varicella vaccine in immunocompromised person, MMRV, not approved for use in person with HIV infections. Do not administer zoster vaccine to immunocompromised persons. Contraindications and precautions are severe allergic reaction to a vaccine component or following a prior dose, pregnancy or planned pregnancy within 4 weeks, immunocompression from any cause, AIDS or other clinical manifestation of HIV infection, high dose corticosteroid therapy. Varicella containing vaccine storage and handling. Store frozen between minus 58 Fahrenheit to plus 5 Fahrenheit, minus 50 and 15 Celsius at all times. Store diluent at room temperature or refrigerate. Discard if not used within 30 minutes of reconstitution. Secondary prevention of spread by the rapid investigations of close contacts to ensure their proper treatment. Prevention and control. Prevention is by live attenuated vaccine in susceptible patients and immunoglobulins. Varicella zoster immunoglobulins are given within 72 hours of exposure has been recommended for prevention. Dose is 1.25 to 5 ml intramuscularly, used for immunosuppressed contacts of cases of newborn contacts, provide in high-risk children with varicella. Control. There is no specific treatment for chickenpox. Notification is must. Isolation of cases for about 6 days after onset of rash. Infection pathogen joined by non discharges. Antiviral drugs provide effective therapy for varicella, acyclovir, palicyclovir, famiciclovir, and foscarnet. Treatment. In mild cases, children calamine lotion and antihistamines are given. In severe cases, adults plus HIV plus patients, acyclovir 850 mg 5 times up to 10 days, and famciclovir 250 mg periods for 10 days, and others are topical antibiotic ointments and antipyretics are used. Tertiary prevention of complication and deaths by early diagnosis and proper management. Herpes zoster shingles. Varicella zoster virus is a primary attack of chickenpox. Virus lies dormant and secondary root ganglia. Zoster is very sensitive to its skin activation. Predisposing factors are age, lymphoreticular malignancy, HIV infection, and sometimes without any apparent cause. Clinical features are prodromal segmental pain, usually excruciating, begins 1 to 4 days before eruption. Morphology, very painful segmental eruption of group papule and vesicle on an erythematous, slightly edematous base. Self-limiting, thrust and healing in about 2 weeks in absence of immunocompromised patients. Sites of predilection, uni and multidermatomal, thoracic intercostal nerves and ophthalmic division of trigeminal nerve. Treatment, symptomatic treatment, specific treatment with antiviral acyclovir, famciclovir, or valprocyclovir. Severe zoster, ophthalmic zoster, immunocompromised patients, and elderly to reduce post-herpetic neuralgia. So, its complication is one of the post-herpetic neuralgia, facial palsy, and secondary infection and colonization. It is the one of the CDC guidelines for the surveillance of the varicella reporting and surveillance, and they have advised us the definition of suspected, probable, and definitive confirmed cases of varicella, and this data is needed for the documentation and monitor the impact of varicella vaccination program on varicella morbidity and mortality. Then it describes clinical and epidemiological characteristics of varicella cases during the varicella vaccination program, evaluate the effectiveness of prevention strategies, and evaluate vaccine effectiveness under conditions of routine use. This was the chickenpox incident in two United States counties, which is shown from 2000 to 2010, and this uh, uh, progressive decline in the cases of the varicella by the implementation of the vaccine and the vaccination programs. Then CTZ recommendation for healthcare professional, as it is being advised that the healthcare personnel who are at high risk should have the vaccination because of the nosocomial transmission of varicella zoster virus is well recognized and can be life-threatening to certain group of patients as well. Reports of nosocomial transmission are uncommon in the United States since introduction of varicella vaccine. Patients, healthcare providers, and visitors with varicella and herpes zoster can spread varicella zoster virus to susceptible patients and healthcare providers in hospital, long-term care facilities, and other healthcare settings. In healthcare setting, transmission have been attributed to delay in the diagnosis or reporting of varicella and herpes zoster and failures to implement control measures promptly. Then there is an overview of the shingles because it is happening in the above 60 years of the people, and they are already with most of the time with comorbidities, and it's very severe for them. One complication, which is the post-herpetic neuralgia, is the most common complication. It is the pain that persists in the area where the rash once was more than 90 days after rash onset and can last for weeks or months and occasionally for years. The other complications of herpes zoster include ophthalmic involvement, bacterial superinfections of the lesion, and cranial and peripheral nerve palsies. Visceral involvement such as meningococcal encephalitis, pneumonitis, hepatitis, and other acute retinal necrosis are also included. Then the monitoring of the impact of the varicella vaccination by CDC is also important because the studies indicate that the overall rate of herpes zoster appear to be increasing. However, introduction of the varicella vaccine doesn't seem to be affecting this increase. Although uncommon in children, the rate of herpes zoster in United States children have been declining since the routine varicella vaccination program began, perhaps because vaccinated children are less likely to become infected with wild type chickenpox virus, which is more likely to reactivate as shingles compared to attenuated vaccine virus. Then it was one of the case report which was published in GPMA. It was a case report of a case of 42 years old man presented with 1 week history of intermittent colic, abdominal pain, vomiting, and jaundice. 2 days prior to admission, he developed vascular skin rash over face and chest. 1 day prior to admission, he passed hard stool mixed with fresh blood. He was recently found to be positive for hepatitis B surface antigen. 4 days prior to his illness, two of his children had a febrile illness with vesicular skin rash diagnosed as chickenpox. He was a fisherman by profession, occasionally drank small amount of alcohol and smoked 15 cigarettes daily for last 30 years. On physical examination, he was jaundice, had pedal edema and vascular eruption all over the body, particularly in the axilla, chest, and face. Few of the vesicles were implicated. He had conjunctival hemorrhages in both eyes. Low and lymphadenopathy was there. Bilateral inspiratory catheters were present at the basis. Abdominal, cardiovascular, neurological examination was unremarkable. His initial then workup was given. His hemoglobin was 13.8, platelet was clumped, creatinine, and the serum aminotransferase were raised. That was 213. CT scan of abdomen revealed nodularity in liver and mild ascites. There was moderate splenomegaly, and the findings were suggestive of chronic liver disease with portal hypertension, and there were always soft tissues infiltrate. Zank smear of vesical lesions were chest revealed, inclusion bodies, and the following inpatient treatment was started with high dose intravenous acyclovir meropenem. He required intubation the following days, and his clinical condition continued to deteriorate with the development of acute renal failure and disseminated intravascular coagulation. He started bleeding from the mouth, nose, and endotracheal tube, and did not respond to aggressive management and died on the fourth day of admission. In this case, the previous history of a chicken pox and has no obvious underlying cause for cellular immunodeficiency disorder. His history and diagnostic workup was suggestive of primary varicella infection, chicken pox. In general, adults with varicella are more severely ill than children and have a greater incidence of varicella pneumonia and death. Varicella chickenpox in adolescents and adults tends to be more severe and should be treated promptly, probably within 24 hours of the onset of the rash. IV acyclovir is a drug of choice. Varicella can be prevented in a recently exposed, unvaccinated, and immunocompromised person by the administration of varicella zoster immunoglobulins. It must be given within 96 hours of exposure to be effective. The reason for poor response was probably the delayed presentation to hospital, which is a common problem in managing these cases in our country. This case highlights the importance of increasing public awareness, vaccination, early recognition, and diagnosis by community physician, and prompt treatment of referral to the hospital for the management to prevent fatal complications. The vaccination of all children and susceptible adults should be considered and may decrease the incidence of this preventable disease. Then there was another article about the chickenpox presentation and complications in adult. It was done on the patient to see laboratory findings the frequency of complications in adult chickenpox patient admitted in the hospital. This study was basically done in the infectious unit in UAE from March 2005 to 2008. The study was designed to include demographic, age, sex, nationality, clinical information, radiological and biochemical changes observed in each patient, and data was entered in performance. And their all investigations and when it showed total of 102 adults patients were entered in the study. The main presenting symptom were itchy skin, rash, fever, cough, sputum, breathlessness, throat pain, vomiting, abdominal pain, confusion, and headache. And as their investigations were done in the all these things, which showed chickenpox in death causes severe symptomatic systematic manifestations leading to high frequency of complication with increased mortality rate, particularly in the older age group and in smokers who develop varicella pneumonia and require mechanical ventilation. Chickenpox is considered to be a benign disease of childhood. However, it can be serious in adults with systemic manifestations leading to high frequency of complications with increased mortality rate, particularly in the older age group, immunocompromised and smokers. Furthermore, despite mechanical ventilation support, antibiotic therapy and ICU care, mortality is still high in varicella pneumonia. It was WHO epidemiological monitor, which showed that Pakistan has a surge or had a surge of clinical chickenpox varicella from April 17 to April 2018, and there were 15,727 cases of chickenpox and 21 associated deaths, with the case fatality rate was 0.1% had been reported. The possible aggravating factor for increased transmission of varicella infection included overcrowding, poor hygiene conditions, and status of immunity of the affected population. In response to the increase in reported cases, the Department of Health Punjab province has strengthened the surveillance for varicella infection to ensure that all all cases are captured by justice system and for effective monitoring of the efficacies of the ongoing public health measures to contain the surge. A mop of health education campaigns in affected areas are being conducted to interrupt transmission of the disease and to bring the surge under control. It was the one of the studies which showed the outbreak of chickenpox in military training center in northern Pakistan. It was a cross-sectional study done from the 1st November 2007 to 30th Jan 2008, in which the patients with clinical suspicion of chickenpox during the outbreak were confirmed by the laboratory test. And there were total 102 cases of this present outbreak. The age of the patient varied from 16 to 35 years, and they were positive by the ELISA. 60% were antibodies against varicella were complementary fixation test. 30% were positive by ELISA, and 12% were positive by immunofluorescence testing. None of admitted cases developed any complications, and the hospital stay remained uneventful. This outbreak of chickenpox in a military training center affected a considerable number of military recruits, led to a number of hospital admissions, and had an adverse effect on training activities. This is a need to formulate a policy to offer vaccination against varicella zoster virus to all unimmunized individuals before induction in the military to avoid unnecessary interruption to training and academic activities. These are the references of the books. And now it's the turn of the multiple choice question. Varicella zoster virus is also known as human herpes virus 1, 3, 5, 2, 7.
7.
No, it's B, 3. Next, secondary attack rate of chicken pox is 75%, 75, 80, 85, 90.
It's about 85%.
Anyone?
70. 90.
90%, yes. Presence of lifelong immunity achieved after infection can be detected by high levels of IgG, M, E, A, or D.
IgG.
A, yes, IgG. Congenital varicella can be acquired by direct contact, airborne transmission, fomites, vertical transmission, orophycal route.
Vertical transmission.
Sorry?
Vertical transmission.
Vertical transmission. D. Incubation period of chickenpox ranges between 7 to 10 days, 10 to 12, 12 to 20, 7 to 21, 7 to 30.
7 to 21.
D, yes, 7 to 21. In apparent infection in susceptible host, while varicella zoster occurs in only 1%, 3%, 5%, 7%, 10%.
10%.
5%. Chicken pox first rash appears on face, arm, axilla, trunk, behind ears.
Trunk.
Yes, D, trunk. Varicella zoster immunoglobulins are recommended. Exposure to a case has occurred between 8 hours, 12 hours, 24 hours, 36 hours, 72 hours.
72 hours.
72 hours. Yes. Most suitable recipient of immunoglobulin is a newborn baby, a pregnant female, 14 years old boy, an old man of 60 years, female of reproductive age group.
A pregnant female.
Pregnant female, yes. Okay, strain of chickenpox vaccines belong to the following groups: live attenuated vaccine, heat killed, formalin killed, toxide on immunoglobulins. Live
Live
attenuated,
attenuated.
yes. It's the key, and thank you.
Thank you very much, Dr. Sadia. Wonderful presentation. Please also announce the result. I'm wondering who stood first today.
Ma'am Mehri.
Well done. Today, the hair clear.
बंद है
Please, are you clearly? Am I audible? Is my voice
Yeah, ma'am.
clearly being heard?
Now you are audible, ma'am.
Okay, thank you. Now, a very good presentation, very important case studies that has been presented, case reports, especially the aspect of the complications in the form of having shingles later on and developing same type of lesion many years after the chicken pox. It is a very important aspect. Another thing that I want to mention is about chicken pox parties, because it has been studied that chickenpox, once it erupted, it causes lifelong immunity, and this is one of the things that people are trying to get natural immunity. And in order to get the natural immunity, one of a very important type that has been seen and observed was in closed spaces like schools, those military camps, and colleges where there is mixing of certain ages. They got it naturally. From this observation, another concept that came up in the recent years was about chickenpox parties. In chickenpox parties, the parents, they deliberately allow their children to mix up with the case of chickenpox in their childhood, and they celebrate it in the form of a party so that those children who haven't chicken pox, or they are at the risk of getting chicken pox in later ages, they get much earlier in their childhood. And that chicken pox party leads to the natural immunity that remains for about their lifetime. However, it is a very dangerous thing. Why it is dangerous? Because it is a type of natural immunity, and there are many things that we know now can lead to a disastrous effect. For example, if any child has